So we've been talking a lot about inclusion, and I hope there is one message that's come across absolutely loud and clear, and that is that quality improvement methods like PDSA cycles, you need a wide-angled approach where issues of ethics, inclusion, and and inclusive design are not add-ons, but absolutely integral to the improvement of healthcare. And to be honest, inequality and inequity haven't been where they should have been in terms of focus. Kaveh Shojania, until recently editor-in-chief of BMJ Quality and Safety, is absolutely passionate about high-quality evidence, cares deeply about those who have been marginalized for far too long. And what we asked him to do was we asked him to look back at the last 20 years of quality improvement. Kaveh Shojania.
The kind invitation to be part of this space and speak to you about the intersection between healthcare improvement and social determinants of health resulted from my having written an editorial on the pathology of poverty a few years ago when Mary and I had the privilege of being editors together at BMJ Quality and Safety. On my title slide, which I think will come up in a few seconds, I have a picture of that editorial and the two companion papers, along with a pictogram of the usual domains of quality, including equity, which I think we can all agree has received the least attention from those working in the healthcare quality improvement space over the past 20 years. I'm not an expert in equity or in the social determinants of health, yet I agreed to give this talk because I've increasingly become convinced that they need to constitute the primary focus for healthcare improvement efforts and really the entire biomedical enterprise. And I think this message needs to be broadcast by as many channels and voices as possible, including non-expert ones like my own. Now, I managed to go about 30 seconds without mentioning COVID. It certainly constitutes a huge part of the context for all of my remarks, but so do the several other massive crises we face at the same time, including the climate crisis, the opioid epidemic, which in parts of the US and Canada continues to exact a toll comparable to that from the pandemic, structural violence against racialized groups, and progressively worsening economic inequalities. The scale of the morbidity and mortality caused by these crises can make any particular improvement effort seem like rearranging deck chairs on the Titanic. Why care about unnecessary lab tests or preventable readmissions or guideline adherence while the world is burning? Well-meaning people have tried to rally the troops with cries of, "We are all in the same boat." But as this poster from the Extinction Rebellion reminds us, while we are all weathering the same storm, we are most definitely not all traveling in the same boat. As Angela Ahuja wrote in the Financial Times, this crisis has broadly separated us into the exposed poor and the shielded rich. If you're wondering when I'm going to start talking about healthcare quality, it's now. And I'll use that quote from the Financial Times as the excuse to do so because gaping economic inequalities were first highlighted by the Italian economist Wilfredo Pareto. Pareto's observation in the early 1900s that 20% of Italians held 80% of the country's wealth resulted in Joseph Juran suggesting in the 1930s that we apply the Pareto Principle, or the so-called 80-20 rule, to quality problems. He proposed that we could identify and target the few causes, the 20%, that account for the lion's share, the 80% of a given quality problem. In other words, a core principle of quality improvement work has its origins in the observation of highly skewed distributions of wealth. My argument that continuing with what we have been doing seems too much like rearranging deck chairs on the Titanic partly reflects the scale of the crises we are facing and seeing their consequences play out every day. But it also reflects the consistent signal that improvement interventions produce small effects, as illustrated in this recent meta-analysis of computerized reminders and other forms of decision support carried out with Dr. Janice Kwan and other colleagues here in Toronto and Ottawa. We sought to characterize the actual improvements achieved by decision support interventions. To do that, we analyzed the trials in terms of the increases in the percentage of patients receiving the desired process of care, the recommended vaccine, the right dosing for a particular medication, the VTE prophylaxis. What we found was that across 122 controlled, mostly randomized trials, computerized decision support increased the percentage of patients receiving recommended care by just 5.8%. To appreciate why this result is so disappointing, a median of 39% of control patients across these trials already received what was being recommended by the decision support. The meta-analytic result of a 5.8%, or let's call it 6% increase, means that the typical percentage in the intervention group was 45%, meaning that over half of intervention patients still did not receive recommended care. A systematic review from 25 years ago that I've always remembered because of the name, it was in the Canadian Medical Association, concluded that there were no magic bullets after reviewing 102 trials aimed at changing professional practice. They found that passive interventions basically didn't work at all, and more active interventions produced small to modest effects. This observation remains true. In addition to computerized decision support, other commonly employed off-the-shelf improvement interventions such as audit and feedback and educational outreach, sometimes called academic detailing, typically improve the percentage of patients receiving recommended care by only 5%. We have more names for the field: quality improvement, implementation science, diffusion and innovation, knowledge translation, and more frameworks for doing the work than we have effective interventions. I'm not saying nothing works, but even the minority of improvement projects achieving clinically worthwhile effects typically take place in just a few wards or clinics. This is a rare example of an impressive national improvement intervention that was well developed and rigorously evaluated. It involved primary care practices in Scotland and reported a moderate to large effect, a 40% relative reduction in high-risk prescribing for NSAIDs and antiplatelet agents. Medications which can cause high rates of bleeding, especially if given to patients with certain risk factors. I want to make clear that this was a terrific, really exemplary project, but it's a narrow target. Only 3.7% of patients even had the high-risk prescription in question, and only a minority of the 3.7% would suffer harm as a result. My point is that we cannot possibly sustain this approach in which it takes so much to succeed, and when we do succeed, it involves such a narrow target. The effort and expense that went into that national intervention would be hard to justify expending, never mind sustaining, unless it addressed a massive medication problem like, say, opioid prescribing. We can't go so many years and expend so much effort to roll out interventions targeting narrow problems like central line associated bloodstream infections or falls or any of the numerous such narrow targets of most improvement interventions. I'm not the only one who would summarize the progress in improving healthcare quality over the past 20 years as limited. Two commentaries in the New England Journal in August of this year, both by leading thinkers in the field, acknowledged the relatively small progress that has occurred over the past 2 decades. Interestingly, they also both mentioned the importance of paying more attention to economic inequalities and the social determinants of health in general. I want to make clear, though, that I don't think this characterization of limited progress applies just to the improvement field over the past 20 years. The vast majority of clinical interventions do not work well. Most interventions, in fact, turn out not to work at all when rigorously evaluated. Acute but very sobering analysis published in PLOS One in, I think it was 2016, showed that once clinical trial registration became mandatory, the proportion of large cardiovascular trials reporting positive results dropped from 50% to 8%. And even those positive results are typically small effects requiring large numbers of patients needed to treat. For instance, to take one example, even among patients with established atherosclerotic disease, for whom lowering cholesterol is presumably a priority, 30 to 100 patients have to take a statin, the cholesterol medication, for 10 years just to prevent one event. And that event is not necessarily a patient death. It could just be a myocardial infarction. And while this medication costs tens of billions of dollars a year, the US paid $20 billion in 2010, 2011 just for generic statins. While we've spent all this money on this medication, almost nothing is being invested in interventions to prevent the problem from developing in the first place. This is typical. We invest billions to develop and then again to deliver treatments for cardiovascular disease, diabetes, cancer, and so on, and little to address the reasons they become so common in the first place. This paper from early September in the prestigious Proceedings of the U.S. National Academy of Sciences highlights the craziness of what we choose as targets for investment in biomedicine. Essentially, this study shows that if we analyze detectable alterations in proteomic, metabolomic, and standard clinical laboratory tests, we can identify patients at risk for various diseases. As one commentator wrote, this might one day be regarded as the first step on the road to precision medicine or personalized medicine. Here's a much cheaper and comparably precise way of identifying risk for numerous health problems, just looking at where people live. Here's an example some of you I'm sure have seen before, using the London Tube map, but with each of the stations showing the average life expectancy for people living in that neighborhood. As Sir Michael Marmot's commented in an interview with the BBC about this map, there are differences shown here in life expectancy comparable to the differences across countries as different as England and Guatemala. Don Berwick, in fact, mentioned this London Tube map in an excellent recent talk he gave for the International Choosing Wisely group, in which he compared the effects of taking statins for elevated cholesterol to these major differences in health outcomes within short geographic distances. And as you can see on the slide, you need to take a statin for 20 years to experience the gain in life expectancy that passes when you ride the D train in New York for just 7 seconds or a Glasgow bus for 43 feet. When one thinks of these various crises we face at the moment, it's hard not to find chilling the famous quality improvement maxim that every system is perfectly designed to produce the results it gets. It's like pointing out that the state of affairs captured by that life expectancy on the London Tube map, or this graph showing the death toll from COVID across racialized groups in the US, are not bugs in the system, they are features of the system. One of the reasons we have ended up here is because we have confused improving healthcare with improving health. The IHI pointed out this years ago with their triple and later quadruple aim, with the relevant aim here being improved population health, not improving the healthcare the population receives. We have focused almost exclusively on improving healthcare with almost no attention to the degree to which actual health improves. In fact, we know it has not improved for the vast majority of the population. Sandro Galeo, the Dean of Public Health at Boston University, has also recently drawn attention to this problematic confusion between health and healthcare in his 2019 book, Well. So what should we do moving forward? Well, the short answer is I think we need to do far less work in clinical microsystems and far more work in meso and macrosystems. For the reasons I mentioned before about the problems with the whack-a-mole approach, the consistently small changes produced by most improvement efforts, the typical choice of narrow targets, the lack of connection to improved health, change fatigue, and sustainability challenges for the minority of projects in clinical microsystems that actually work, these all argue for a shift in the targets on what we work on. I think that if we're going to do any further projects in a given ward or clinic, it needs to improve more than just one of the quadruple aims. It needs to not only improve patient outcomes, for instance, but also improve staff morale. Or it needs to improve multiple targets, as with culture and teamwork interventions. And I've shown a couple of examples here, one from the United States, from Leslie Curry, Betsy Bradley, and others, showing improvements in the performance and outcomes for patients with acute MI, based on how well people improved in a culture change intervention, and a similar project but focused on safe maternity units from here in the UK, led by Elisa Liberati, including Tim Draycott, Mary Dixon Woods, and others. The meso-level example I want to give involves helping long-term care homes during the pandemic, and the key piece of context for this example is that the vast majority of Canada's COVID deaths have occurred in the long-term care setting or in nursing homes. We call them long-term care centers here in Canada. This headline from the Globe and Mail comes from June, but with the second wave upon us, the same pattern is repeating itself again, with many long-term care centers and retirement homes having outbreaks again. In that context, some colleagues at several hospitals in Toronto rapidly put together this massive and frankly inspiring collaboration in which 6 hospitals provide specialist care to 52 long-term care centers. This collaboration has involved not just those 6 hospitals and 52 care homes, but also the City of Toronto's ambulance services, community providers of laboratory tests and diagnostic imaging services, and other community organizations. The way the program works is basically that GPs covering the residents at the care homes can send a consult request and 24/7 receive a call back within 30 minutes from a physician specialist or advanced practice nurse based at one of the hub hospitals who can provide advice and also organize services, including on-site diagnostics, as well as some intravenous treatments, and can arrange follow-up virtually or in person as needed. Analysis of the data in September, after being up and running since April, showed that several of the care homes, the ones that had been early adopters and used the service at least 10 times, had sustained 25% reductions in the frequency with which they sent these frail elderly patients to the emergency department. The macro example I want to offer involves addressing homelessness, a topic I was reminded of when I read this piece in the Globe and Mail by one of my colleagues, Dr. Stephen Wong, who is also a hospital-based general internist, but works at a hospital with a more inner-city population. Stephen has focused his research on ways to improve the health of his patients, not just the care they receive, by addressing their homelessness itself. One of Stephen's past studies was this randomized controlled trial with Vicky Sturgiopoulos, a psychiatrist here in Toronto, and many other colleagues across the country. This randomized controlled trial was published in JAMA in 2015. It involved 1,200 homeless adults with mental health issues in four Canadian cities. The intervention group received scattered site housing, which means that they were given rent subsidies to live in regular apartment buildings, not be concentrated in complexes filled with just people who had been formerly homeless. And they also received off-site case management services. While there was some variation across the sites, you can see that the results were consistently positive, with a 30 to 50% absolute increase in the days of stable housing. The health outcomes in this study were secondary outcomes, and they were unfortunately not statistically significant, although, if I recall correctly, one of the cities did actually have a statistically significant reduction in emergency department use. My point is that the next step here is clearly iterative refinement of this sort of intervention in order to optimize it and achieve actual improvements in health. My point moving forward is that this collaboration or collaborations of this sort between improvement experts and those developing these sorts of macro-level interventions addressing a key determinant of health, namely adequate housing, seem more worthwhile than continuing with the many microsystem improvement projects we have pursued over the past 20 years, or most of the larger scale ones targeting specific aspects of healthcare delivery, like inserting a central line. Another example target for macro-level health improvement work would be universal basic income, which had started to receive increased attention in recent years, even before the pandemic. And since then, as many of you may have seen, it's been pointed out that some of the bailouts to help people who have been affected by the pandemic resemble universal basic income interventions or ought to be turned into them. These interventions have an interesting history, and some have achieved impressive results. Almost certainly they will need iterative refinements as they are developed and implemented. And again, this sort of iterative refinement is what those with improvement expertise typically undertake. It may seem Pollyannish or naive to suggest we work on such big problems, but as the editors of The New Yorker wrote in a theme issue in late September, in the face of such widespread, massive challenges, what may seem like radical suggestions may also represent the most realistic prospects for change. In his book Utopia for Realists, the Dutch historian Rutger Bregman does a great job of making realistic cases for several radical-sounding policy interventions, including universal basic income, shorter work weeks, and freer flow of people rather than products across national borders. Reflecting on the effects we typically achieve with healthcare itself and healthcare improvement efforts, I just do not see how we can make any meaningful improvements if we keep focusing narrowly on improving specific aspects of healthcare delivery rather than on improving actual health. And once we make actual health our focus, why would we focus on anything other than the social determinants of health? They account for most of the good health some of the population enjoys and so much of the poor outcomes the rest of the population suffers within a given city, province, or country. In one of the installments of the Pirates of the Caribbean franchise, Keira Knightley's character says to Johnny Depp's Jack Sparrow, "There will come a moment when you have the chance to do the right thing," to which Johnny Depp's character replies, "I love those moments. I like to wave at them as they pass by." I worry that if we do not start aiming our improvement efforts at reducing poverty and the effects of it and other social determinants of health, we will essentially be waving as this moment passes us by. With that, I'll say thank you again for the opportunity to address you during this terrific event, and I'm happy to take any questions. Thank you.
Kaveh, that was terrific. It managed to be both inspirational, provocative, and actually profoundly shaming at the same time. I had a question for you, which was, you know, there are multiple problems, you know, COVID, there's climate, and we tend to look at all these problems in separate boxes, but actually we need to tackle them all at once, surely, if we're to go for this macro approach.
Oh, sorry. I was actually literally just now getting a phone call from some international country trying to scam me on long distance charges, but I just turned it off. I think that's a great question, Vivian. That's really been the main point of my talk, because I'm not pretending to know the answers to these questions. I think I've been thinking a lot when you hear these statements like we're in the 11th hour for the climate crisis and so on. Another famous quote involving an hour is Einstein's line that if I had an hour to solve a problem, I'd spend 50 minutes thinking about the problem and 10 minutes solving it. I feel like we have not laid in front of ourselves these massive crises that we face, these problems. And the reason I think we need to do that is, as many people have commented, if we're not careful, our efforts to solve the COVID crisis will actually worsen some of the inequities we already have, the climate crisis. Another one, which I didn't mention in my talk, is surveillance capitalism. I mean, I don't know if you've read, there's this great book of that title that came out a couple of years ago. And if we're not careful, the track and trace apps and so on, I mean, they could just be harnessed as part of the surveillance apparatus that has distorted so much of our lives these days. So I know it's sometimes when you start talking about these things, you sound like an insane conspiracy theorist too, but another message I really feel that I want people to take away from this is that message that the problems we're facing are not bugs, they're features of the system. I mean, that famous QI line that every system is perfectly designed to get the results it gets. Like, how can you look at the world and think you're just going to keep continuing to do what you're doing without really stepping back and working with people across multiple sectors to try to define these problems at the same time?
And you mentioned about inequity because of COVID, but actually what we're seeing with COVID is that we're getting major between country inequities developing because of COVID, and that will be very, very long lasting. How do we avoid those?
Again, I don't pretend to know the answer to that, but I guess I would say the one I worry more about the one inside our own countries. I mean, I showed the London tube map because obviously this is a talk for the UK, but right now the map that gets shown where I live is a map of Toronto's neighborhoods by income that was collected by the city a few years ago. And when you overlay the COVID map, it's a perfect match that the places with the lowest income are the places with the highest COVID. I think something like 80% of Toronto's COVID cases have happened in people with an income under $30,000 a year and or non-white. So I feel like the inequities right now, in fact, there was a great report by some group, I forget which NGO in Toronto, pointing out that one of the mistakes is to try to have equity in the sense of a universal solution, when a little bit like with affirmative action sort of discussions, we need to recognize that some of these neighborhoods need very different solutions and we need to focus our resources there. At the country level, I don't really know what to comment on that.
A question here from Carol Sinnott. Thanks for a provocative talk. Do you think the pandemic has helped improve appreciation for macro level interventions instead of the micro person level interventions held by healthcare professionals and patients?
It's a great question. I mean, I know everybody quotes that cliche line about every crisis is an opportunity or whatever that thing is. And again, this may make me sound crazy, but everyone always talks about, let's say, Darwin's theory of natural selection and evolution has been used as an analogy of so many odious political philosophies. But when you actually look at the evolutionary record, things actually happen very suddenly. And I think the same is true in public health. Like when you look at, we make structural changes and they suddenly have a big effect. Everything else is usually just tinkering. And so I would say that this disruption that COVID has caused provides us the opportunity to make structural changes. But actually, as Naomi Klein warned in a great video in April, you have to be so careful that when you respond to these massive disruptions, you don't just use the usual ideas that are lying around. I mean, we saw that after September 11th in the United States. I mean, those terrible ideas that the Patriot Act encompass, they've been lying around for a long time. Those people had wanted those hawks had wanted those things to happen. And believe me, there's a lot of companies and vested interests that are waiting to implement things that I would say are worse than before. But there's no question that this disruption has at least opened up the conversation to consider some major changes in how we do things.
Let me bowl a provocative question back at you.
Okay.
This comes from John Brown. To what extent do you think macro centralization initiatives in acute care, which are usually engineered under the guise of quality and safety, have contributed to inequality by downgrading services for rural populations, which tend to be poorer to begin with?
It's a great question from John, who I believe if it's the John Brown, who's the editor of BMJ Quality and Safety. Hello, John. I will say that that's very true. I mean, I think that in quality improvement within a hospital or a health system, we've often take the let 1,000 flowers bloom and see what happens approach. You just say, let every ward do their own thing or every little clinic. It never really does anything terribly useful. But I do wonder if we could take that approach at a macro level, not at a country, but more like let different cities or rural areas try what would be called macro level experimentation. I mean, in my country, in Canada, that is so important. I mean, it's hard to convey to people that, let's say in a country like England, I mean, we have 30 million people spread out over a country where each province is like the size of France, right? I mean, like where I grew up, there's a lake the size of England, right? So, I mean, you can't possibly think that the same solution in Toronto will apply to Red Deer, Alberta, or wherever the case may be. So I think I agree with John that we have to be careful to not have overly centralized planning, but I do think that when we distribute the interventions, they can still have a macro focus, but maybe at more of a city or regional level rather than the entire country.
And here's another, it's a very difficult question, but what can we actually do to improve the main causes of inequity in health, poverty, housing, education, status, esteem? I mean, where do we start? I mean, I suspect some people are just put off by the sheer complexity. It's the too difficult, and it's resisted. I mean, we have a lot of populists around at the moment who are not much into public health. Public health is Cinderella, as it always has been. And the minute you say anything about, for instance, unhealthy foods, nanny state, that's the end of that.
I think for sure, it is potentially depressing when you think of the scale of it. Although that's actually why I like that Rutger Bregman book. You come away with it feeling actually strangely inspired, the Utopia for Realists. But I guess I would say, I used to think that, for instance, especially in Canada, I often thought I had to be at war with my basic science colleagues. And the reason I thought that is that, I mean, so much of what we do is the same biopharmaceutical model, but we don't have the deep pockets of the United States or maybe England or some other country. So I always thought it was sort of pointless because it's not like, I mean, insulin was invented in Canada. It still costs a lot of money. Like you don't get a discount just because you invented it. But certain types of research, like how to deliver healthcare maybe, or improve population health, there is value in having developed it locally because it's not just a pill you can take off the shelf. And so the expertise that's often not captured in papers is really valuable. The reason, though, I don't think that war needs to happen as much anymore is actually all this research on the vaccine and so on has reminded us that, yes, basic science research is important, but we got to make sure we point it at the right target. And I mean, the reason we need to have these conversations at a sort of a higher level is right now, actually, today's news in Canada is that Trudeau announced that we may get the vaccine a lot less after other countries because we can't actually manufacture vaccines in Canada anymore. I mean, that's another example, that sort of just-in-time production that has become so common. It's like crazy that we have that, and yet We've seen with the supply chain disruptions in COVID that maybe more local production is both good for the climate and for fighting future crises.
You know, I hate to stop you in mid-rant, but I'm afraid I'm going to have to. And Mary Dixon Woods, please, please, can we have this man for a whole day and a whole session? Because I think that, you know, there's a mass of questions here that we've not had a chance to answer. Thank you so much. It's been very provocative, and thank you.
Thanks, Vivian.